We want to again thank you for being on this call today with Monica Rebella, CPA and President of Rebella Accountancy, which is a CPA firm that specializes in accounting, tax, and consulting services for hundreds of dentists in California. Our topic of the call today is most common operational issues encountered in dental practices. If you're not a current client of Rebella Accountancy or you have not met her, Monica Rebella is a CPA and has 27 years of accounting and tax expertise, which includes 13 years working with the Big Four, Big Eight firms, and over 13 years experience working with dental practices. She is past president of the Orange County, Long Beach chapter of the California Society of CPAs and is a member of the AICPA. She has conducted training sessions for accounting firms as well as lectured on tax and business matters to the California Society of CPAs, UCLA Dental School, and the Orange County Dental Academy. She runs her own firm in Tustin, California, providing accounting, tax, and consulting services for over 300 businesses throughout California, specializing in dental offices and small businesses. Monica, welcome to the call.
Thank you, Jeff, and thank you to everybody this evening for spending time with us. I think that you're going to get a lot out of the operational issues and solutions to them this evening. Our special guest tonight is Eric Vickery, as Jeff mentioned. I'm going to give you a little background here for Eric. Eric and his wife of 18 years have 4 children and live in Redding, California, so just up north of us here. As soon as he got his 4-year degree in business administration, he decided he wanted to work in dental practices. So since that time, which was 1998, he ran off and started managing dental practices with local dentists. He's been coaching dental offices ever since, and he has coached over 200 practices all over North America, not just California, but he does it on a nationwide basis. And he's also done a lot of lecturing. Some of his topics that he has lectured on is stopping cancellations, case acceptance, how to be an insurance independent, or how to be independent from insurance, I think, and several other topics. So tonight we've reached into Eric's background to help us with what he's seen as a dental consultant working with dental offices as the most common operational issues these days and solutions to them. So, Eric, thank you so much for being here.
Hey, Monica, thank you so much for having me, and Jeff as well. I really appreciate the opportunity to speak with you guys on this topic. I really was thankful that Monica was willing to look at this side of the practice with everyone and really feel like this is the best opportunity in a short window to look at what are the hot topics for dentists right now when it comes to really managing your practice from the operational standpoint. What are the biggest issues my clients are constantly coming at me with? And, obviously there's going to be a variation. There might be a top 10. But when we talked, we decided, let's keep it to 3 things that we felt like would be the biggest 3 to give you the most bang for your buck. And so each office really has to determine what are their top 3. And so you have to be able to diagnose your practice. You have to be able to look at your practice and diagnose, how's my performance? How's my practice performing? And if you don't have a way of evaluating that, there are solutions on how to just do that part. But really you got to be able to ask yourself some questions. First of all, how do you know your practice is running at an ideal rate, at an absolute efficient rate? We're not going to compare apples to oranges here and talk about big numbers, annual numbers, but we look at that production per patient or that how much open time is in your practice, those types of things. So we'll talk about that. So you have to have the monitoring in place to be able to diagnose, where am I with my practice? What's the pulse of my practice? So we spend all day long with patients diagnosing their concerns, their conditions. We have to remember that as business owners, we have to step out of that role, step into business owner role and know what is the pulse of my practice, what's really happening here. And that's the business side of it that we'll spend some time on today as well. So from that, once you're evaluating that, you probably see your big 3 or 4 things that are glaring. In this case, Monica and I have decided that these big 3 were the most glaring operational issues and how to solve them. And of course, in an hour tonight, we're gonna scratch the surface. There's a lot more we can get into, but this will at least get everyone going in the right direction. So the first one we're going to talk about is increasing patient flow. And we could spend an hour just talking about reactivation, getting your patients who have seen you in the past who do not have an appointment right now, getting them back in the schedule. So we'll talk about that and knowing what the system is for that, whose job that is. Obviously, the big one everyone talks about is new patient flow. Making sure that not only are you getting the phone to ring, but once the phone rings, is your team trained on how to get that patient in the door and happy that they're scheduling with you. You know, we don't want people reluctantly scheduling and then not showing up for appointments. We want them happy that they've called your office, happy that they've reserved time with you. So the biggest, most glaring statistic that stands out to me every time I talk about new patient phone calls is the fact that 64% of the time that patient calls in, our scheduling coordinator simply doesn't ask if they want to schedule the appointment. So we'll talk about that process tonight. And really, what are the best marketing sources for your area? Because every area has a difference in their big three, and we'll talk about those tonight too. The second most common operational issue is case acceptance. If we get the patient in the door, that's still a loss leader as a new patient. The follow-up, the continuation of that is making sure that the patient says, yes, ultimately you want to be, as a clinician, as a dentist, you want to be providing ideal dentistry for every patient that comes to the door. Now, we know we have a target of about 85%, but sometimes it's not just about that percentage. It's about how much is each patient doing to get healthy. Are they just, you know, inching along and one thing at a time and really not getting healthy because it's snowballing and things are getting worse and worse in there? We want to talk about how to help you present in a way that doesn't make you feel like you're selling, but it makes the patient feel like they're getting really good advice from somebody they trust. That's what we want to have happen. So we'll talk about presenting cases in the ideal way. And then the third issue is obviously making sure that you're getting paid fairly for those services you're providing. You know, you are not the bank. You run a business just like many of your patients do. And your employees, they want to be paid and they want to have raises every year. And so the employees have to be trained as well on how to make sure that the financial arrangements are set up proactively, not reactively. Again, another topic we could spend hours talking about. So we're going to jump into this and just make sure that everyone has a good understanding of these big three things in a general sense. And obviously there's more information to follow if need be. So and we're going to tackle this based upon how the patient flows through the practice. So in other words, you know, financial arrangements, that might be number one, but I want to get to that point in the process. So we're going to start with that new patient phone call coming in. We're going to talk about, then we presented the dentistry, and then we're going to talk about making sure we have financial arrangements. So we're going to talk about in the flow of the patients moving through your practice, even though some may be more of a priority than others. So quickly here, the ideal practice, you know, when you're diagnosing, you have to be comparing yourself to yourself. But there are some industry standards that, you know, Monica and Jeff and I, we talk about with our clients, and we make sure, hey, these are the norm. You have to be in this ratio. For example, one would be your collection rate at 98% or better of what you're producing, or making sure your accounts receivable is no more than 50% of an average month's production. We're comparing you to you when we do that, not you to somebody else's practice, but we know those measurement tools will apply in any practice. So do you know that? Do you have the answer to that? So here are some examples. So making sure that your doctors, you're producing at a rate of $500 per patient and $500 per hour minimum. We've got to be above that. And there's ways to make sure we're doing that. If you're not, hygiene side, same thing. Same number per hour, same number per patient. About 175 to 200 at a minimum. That's where we start. Another one here we can look at. Now, there's a big range here. New patients coming in, an ideal rate for each practice could be different. The well-established practice that's got a long wait to get in, they may be more on the side of 15 new patients a month. But most doctors that we run into, they want to be somewhere around 25 to 30 new patients a month because they want to grow. They've got their existing patients healthy. On a side note, let's define a new patient. when we're looking at new patients, when it comes to marketing and what's happening in the practice, we are not talking about children. We are not talking about emergency patients. We're talking about adult comprehensive examination appointments, meaning when you do a D0150, that's when we count a new patient entering the practice. I'll give you an example. If an emergency patient calls the practice and we do a great job getting them in, we get them out of pain, what are the chances of them actually coming back? The chances diminish. Versus if we have that same patient call in pain, but with good phone skills, we're able to convert them to a comprehensive exam when they come in. We know that statistically speaking, we got a greater chance at keeping that patient in the practice as a permanent patient, as an actual active patient, not a one and done. And so if we're going to spend marketing dollars, we want to make sure we're getting our value from that. And children, their parents bring them in. Children are great for the practice, great for hygiene department. We have a future in a patient base by doing this. You're building rapport with the entire family. A lot of times parents send their kids in first as the guinea pigs, and then the patients will come in, the parents will come in as patients. And so we want to make sure that we're accepting of that if that's how your practice is set up, but we don't count them as an actual new patient. They didn't find the marketing source and call the practice and come in, and honestly, their treatment plans typically don't equate to an adult new patient. So again, we're trying to add value, create value for our new patient count. Doctor time. A lot of times I'll ask my clients, how much open time do you have each month? Oh, about an hour a week or whatever it might be. And that's an opinion. We want fact. And so are you measuring how much open time you're ending up in doctor's side and on the hygiene side? And are you able to hit your goals of keeping the doctors? Most doctors work about 100 hours a month on average. And so there's 3 hours or less per month open in the doctor's schedule. And on the hygiene side, about the same, about 7%, 7 hours or fewer. Some offices, 5% is a good goal. Some offices, not so much. The national average is 33%. The reason that is so high is because the clinics that are involved, we're taking statistics from the clinics, the bigger practices that have a lot of patients coming through and therefore a lot more open time. The question is, are you monitoring that? Do you have your finger on, your pulse on the practice? So, and I mentioned earlier, case acceptance is not just about having an 85% case acceptance rate, but it's about how much dollars are you presenting, how much dollars are you accepting. And as Monica and I know, dealing with money doesn't mean it's just about the money. We know that the more dentistry we're doing with patients doesn't necessarily equate to healthier. What we want to see is a healthy number, and a healthy number means a healthy patient. For example, the amalgam filling versus the on-layer composite filling or maybe a crown. Obviously, the amalgam filling is a way to stop some problems, but ideally that's not the treatment we want to be presenting. And we know that amalgam is a lot less expensive than the ideal treatment. And so when we see that treatment dollar go up, we know we're presenting and getting case acceptance for more ideal treatment. The question I present to the dentist in this scenario is I say, okay, you got two hygienists. One's getting 85% case acceptance and one's getting 50% case acceptance. Which do you hire? Which is the one you want to take from the other practice and have it work in your office? And 9 times out of 10, the doctor says, well, I want the one getting 85%. And then I say, well, let me give you some more numbers. The rest of the story is the one who's getting 85% is getting $8,500 scheduled in the doctor's schedule because she's presenting $10,000 a month, living in a very safe zone, a very need-based direction, maybe even almost fearful of presenting things that the patient ought to be considering. Whereas the hygienist who had 50% case acceptance, she had $25,000 scheduled based on $50,000 presented. And then I asked the question again, which one do you want to hire? And 9 times out of 10, they switched their decision. And those 9 who said 85% say 50%. So, yes, we want a high case acceptance rate, but we want it based on a certain number. Do you know that number? Most offices aren't paying attention to that, and therefore it's hard to judge what needs to be fixed. And then lastly, I'll just say this, is making sure that your hygiene department is operating at 35% periodontal focus. We know 80% of the population has gum disease. Half of them don't go to the dentist. So 35 to 40% of them in your practice should be being treated. Or are you doing super prophies and ignoring the problem and therefore looking at issues down the road with patients and your practice? So if you don't know those numbers, I'm happy to help you out with that. Make sure you got something in your practice to help you calculate these things. Make sense? So let's start with the first area of concern, which is when the patient calls in. Are we able to convert that caller into a live patient in your practice? You're spending marketing dollars. We want to make sure it works. So in doing so, we have to have tools that we use in the practice. And the first tool we use is the law of research. And the law of research says the more you know about the patient when they're in your chair, the more they think you know about what it is you're doing, dentistry. So you've all been in the physician's practice when the lady at the front desk, the nurse, and the doctor all introduce themselves and ask you the same question. What's the reason for your visit? And that gets repetitive, and it starts to create a negative connotation in the patient's mind. People here don't communicate. What we want is that doctor to walk in the room, initiate case acceptance by saying, "Hi, Ricky Bobby. This is Dr. Vickery. I understand you spoke to Monica on the phone. She shared with me that it's been a few years since you've been to the dentist, and it's not your favorite place, and we get that. Today will be very straightforward and easy for both of us. And I want to let you know that we're aware of that, and we're taking that consideration. And she also shared with me that you have a major concern on the upper right, and I want you to know we're going to talk about that today and come up with a plan together. What were the other things that you want to share with me before we get started?" Okay, so all you're doing is you're laying the groundwork telling this patient, wow, they communicate. I said that to Monica on the phone, and now the doctor's aware of it. I don't have to repeat myself. And what I call that is we're creating confidence in the dentist's competence. Every interaction that patient has with your office determines how good of a dentist you are in their mind, in their perception. And perception is reality. So did the phone call go well? How did the reception area look? Did I sit there too long, or did they see me on time? And what did the clinical team members say when they came in the room? Were they repeating themselves, what we talked about before, or was it a wow factor? So this is all about the law of research as we proceed through the rest of our presentation on the phone. So we know that the phone is your number one marketing tool. Without the phone, patients have a real hard time getting into your practice and scheduling. There are ways around that these days with email and things like that, but the phone is always going to be number one. And so if your administrative team is treating the phone like it's an interruption or a nuisance to their day and getting things done and checking out patients, we have to change that base of thought. We've got to make sure they understand that that phone ringing is what we want to have happen, okay? And so wouldn't it be great if the only time the phone rang was when a patient was calling to schedule or a new patient was calling to find out about your office? That's what we want to have happen. That's what we want to see happen in the practice. Obviously, we're going to get other calls. We're going to be calling insurances. We're going to be getting patients calling maybe to reschedule or things like that. But the goal is that phone rings, our mentality automatically switches to, wow, a patient must be calling to schedule. So how do we get the phone to ring? Now, there really are three big ways to get the phone to ring. And you have to determine in your area what's the most productive way to make new patients call your office. The big three, you've probably heard of them, whether that be direct mail done appropriately, radio advertisements, or advertising in some sort of magazine or periodical. Those are typically the big three that we spend money on to get patients to call the practice. The question is, well, how much money do I spend? And so the statistic that you want to be aware of is you want to be somewhere between 2 and 4% of your average monthly collections spending on marketing. So obviously if you're a $100,000 practice, $4,000 a month, that's a healthy budget for what you're spending to get that phone to ring. Another statistic, this is in general, this isn't just in dentistry, but we know that those are branches that you're throwing out there. Let's say you're putting all of your eggs in direct mail and you're doing that. It's causing the phone to ring. And let's say you're getting 10 families a month from that to come in. What we know is that those are branches. Those are 10 new branches that come into the practice. And once that family number one comes in and we have a great experience with them, they have a great experience in our office, we know that now they are more likely to refer 4 more families to our practice. 3 to 4. It's about 80%. So number one is always going to be personal referrals, because even when one external marketing source works, that branch has got 4 more referrals coming in from it if we're doing a good job. You have to make sure that this ratio is healthy in your practice. Even when you're spending money, we're still going to see a greater number coming from referrals. That brings up, how do you ask for referrals? Make sure your team has a system and they're comfortable with how to ask for referrals. Jeff and I have worked on this before in the past, and we've talked about it. You have to create the opportunities where your team is comfortable getting to a place where they say to the patient, how would you feel? Would you be comfortable in recommending our practice to your friends and family? And letting the patient say yes, and then having a referral card ready to go. You have to have that system in your practice. So, again, more information that's out there on this. Happy to help with it and get that information to you guys on how to do this. So, remember, the big 3, direct mail, radio, and periodicals, you got to have one or all 3 of those going. But the most important part is then nurturing those referrals, those personal referrals within your practice. Okay.
So, Eric, if I can stop you there, direct mail in our area doesn't work well.
Yeah.
It's oversaturated. People are looking for the freebies. So, in talking about these 3, the big 3, you're saying that they should concentrate also on radio ads and periodicals. And what do you mean by periodicals?
Yeah. So, again, like I said in the intros, one of these big 3 ought to work in your area. Now, you can do a demographic analysis by any marketing company. We'll say, all right, let's look and see what's going on in your area and what works with these demographics. Is it radio? Is it advertising? Or is it direct mail? And in a lot of areas where there's a lot of dentists, the direct mail no longer works because everybody's doing it, and the patient's jumping from freebie to freebie, right?
Yep.
And so the radio could be, you advertising on the radio, your voice as the dentist advertising how you allow patients to relax in your office through sedation dentistry. That's a big tool that gets the phone ringing. You asked about periodicals. A lot of towns now will have I call it a Your Town magazine. So, if you're in Santa Barbara, there's a magazine called Santa Barbara. If you're in Anaheim, there's a magazine called Anaheim. And in there is a great place to see, hey, should I be marketing my dental practice in this magazine? If so, what's my approach? Most dentists I work with are not the, hey, come in for their freebie type dentist. They are more of, hey, we're providing a comprehensive atmosphere for your family, and here's what we can do to make sure you're comfortable here, whether it's sedation or maybe even some type of orthodontics or implant specialty. You come here, you get all done here, those types of things. And so we want to advertise benefits that the patient receives.
In the local area. Yeah.
Exactly.
Because we have been very, very clear that the number one best resource for new patients are happy clients.
Yep. Referrals will always be number one. What happens, let me ask you this, Monica, what happens when you ask every single one of your patients 4 or 5 times for referrals and there's no more there, that well is dry?
Right.
We still have to have that outside source trickling something in, a new branch each month coming in, or 2 or 3 coming in from this source, so that now we have a new well to go to ask for referrals.
Right.
So that's the important part of it. And so how you do the marketing is also really important. If you're doing an advertisement in a local magazine, we offer this so that benefit to the patient. We offer this so that you're receiving this benefit. All too often, the mistake is made in advertising saying, this is who we are. Here's a picture of our team. Love us. Come see us. We offer CEREC. We offer Invisalign. We offer this. But they leave it at that. Patient doesn't know what that is.
Yeah.
It's half of what you need to be putting in the advertisement, right?
Yeah.
Yeah. So showing the benefits, the patient's going to get the phone ring. And what we find is you might get less new patients from that advertisement than you would if you're offering something free, but the patients you get stick. They stay in the practice. That's what we want to see.
Go ahead. So I get that. They need, you can only ask for a referral so many times, and you have gone to that well enough, so you need that other one. But let's talk about a doctor who has got a fee-for-service practice. I've heard from doctors now as I've plateaued. I'm fee-for-service, I've plateaued. We're thinking about taking on insurance. So, have you heard this?
Yes, I have. I've heard it from that doctor, and I've also heard it from the graduate getting ready to go out, and they finish their residency, and they're ready to open up shop. They're going to start from a scratch practice, too.
Yep.
And the same, when I look at the numbers, and I help dentists get out of Delta, I help dentists drop insurance plans and get out of network, because the statistic is you could lose 20% of your practice base, right? Or just that has that insurance plan, right? So it's not really your practice base, 20% of that plan. But you're increasing your fee 20% for the 80% who remain. So you can work smarter and not harder and be outside of that insurance plan and make it work. The other part of that is when this Louisville dental student was saying, I'm just going to participate in all the PPOs. I'll get all these patients, and then in 10 years I'll drop it. Well, what type of patient are you attracting when you do that? Do you think that when you drop the plan that bait and switch is going to work? They're not going to be receiving the kind of dentistry that they signed up for to begin with, which was, hey, I'll call you when it hurts. Or, I come every 2 years. I happen to miss my last appointment, so I'm here on my 4th year. So which patient are you looking for? And so if you start signing up for these plans, you're going to see a different kind of patient show up in your practice. And if that's your vision, that's okay. But I can tell you this, the patient who you're used to seeing doesn't open up their insurance booklet or insurance website these days and look for a dentist on their list. They go to their fellow employee that they trust. They go to their family member that they trust, and they say, where are you going? They go online and look for your website. They look at your Yelp reviews. That's what they're looking for these days. And then they call you and they say, do you take my insurance? And your team has got to be trained so that they can handle that question to show the patient, yes, you can come here. Our patients who have the same exact insurance as you come here. They love it. We file your claim for you, and they go through the whole process with them. And if everybody's trained, anybody can pick up the phone and have that conversation. Does that answer your question, Monica?
Well, kind of, because you're saying
okay.
We accept your insurance, but if you want to, what I heard you say is they should get off of insurance because you're going to receive more from the patients that come than a reduced fee because you're taking insurance. But you said when they call, you can say, yes, we take that same insurance. We'll help you
bill
process
that insurance. Yeah, the language is we have patients who come here who have that same exact insurance. We bill that insurance electronically. Let me explain. I'd be happy to explain to you how that works. And you can get in a conversation with them. And that takes some training and some skill, but it's doable. And my experience shows me that the dentist who's the least stressed is the one who's getting, 95 cents on the dollar, not the one who's getting 80 cents on the dollar or less.
So what you're basically saying is they're out of area provider. So they're going to
out of network provider.
So they're going to ask the patient to pay all the money up front, but they'll send the paperwork in for them to be reimbursed.
Could be. There's two options. Yeah, it could be that option, or it could be they're out of network and the insurance check comes to you and the patient's just paying a difference at the counter. There's two ways that you can go, and that's why I don't want to get too involved in the verbal skills because with different offices listening, what you say is going to be different. But the bottom line is it's doable and it works. And so for the dentist who's been practicing for a long time and says, I'm thinking about signing up on an insurance plan, we've got a lot of numbers to look at before you make that call.
Yeah.
And my experience shows by signing up for insurances, all you're doing is giving the existing patient base about a 20% break, and you're not getting new patient flow because you're on that plan. That's a generality. There could be some specifics that would exceptions to that rule, but for the most part, that's what I see. And so I'll be in an office in 2 weeks in Sacramento area and, just getting away from the Delta process. Delta's a big deal right now in California. There's a lot going on. It's a hot topic. And so Delta's going to be making some changes. Which side of the fence are you going to be on? The side that eats up, 30% of your profit right off the top when your profit margin might be 25%? So you're paying those patients 5% to come in. Or are you going to see fewer patients and make 20% more? What's your vision? And I'm not saying one's more right than the other. It all depends on the area. But my experience shows that it's doable.
Well, I think that people will be excited to hear that. So I'll
Yeah.
let you go on.
Absolutely. So marketing sources are important. We've got to have to make the phone ring. As Monica and I have said, you're still going to have to make sure you have a great system in place for asking for referrals. That well does dry up. You got to have one of the other big three going. We got to figure out what that is for your practice, okay? So once we get the phone to ring, okay, the phone rings, the team member is thinking, yes, the phone's ringing. The mentality is a positive one when they pick up the phone, okay? When they pick up the phone, we have to create a system for that process. We have to have verbal skills. We have a system for it, and we have to make sure the team is trained. And so I'll let you think about this question for those who are out there just for a moment before I answer it, which is, how long should a new patient phone call take? You're thinking about this. How long should a new patient phone call take? You know, if you're a dentist, you don't answer that phone, so you don't know. Well, I hear anything from 2 minutes to 20 minutes, okay? My answer to this question is all of the above, or however long it takes. Our mentality is based upon who's calling in. You know, if Donald Trump calls in and he's in his car and he just drove by the office and he says, that's where I want to go, then it's probably going to be a quicker phone call for me to get this person scheduled versus, you know, grandma just moved into the house. She came from Alabama. I'm scheduling. Here she is. She's going to schedule her first visit, and she's slow as the South. You know, she's just easygoing and wants to take some time talking to you, find out if this is the right place for her. You've got to answer those questions. And so are you the type of team member who can wear different hats, and do you have the training to do that? We said the answer was however long it takes, okay? So that brings us to my second question here is, what is the most important question we should ask that new patient when they call in? So, Monica, you're outside of dentistry a little bit. You're not in the dental office every day. If I were to ask you the question, what would be your first gut answer? What is the most important question we should ask a new patient when they call?
How did you hear about it?
Okay, what's the marketing source? Okay, I've heard people say, get their name. That's the sweetest sound in any language, right? What's the reason you're calling for? What's the primary reason? Okay, how long has it been since you've been a dentist? All these questions are important, okay? Now, Monica, I'm going to do something. I'm going to rephrase my question for you, okay? So what is the goal of every single new patient phone call that we get? What's our goal as a dental team member?
Make them a patient of our office.
Yes.
Make them want to come and be with us.
Exactly. Get an appointment scheduled, right? That's the goal. Now, not every patient's a good fit, but for the most part, that's our goal. Can I get this person scheduled? So when I phrase my question this way, what is the most important question I could ask to make sure that I get this person scheduled? What do you think the answer is, Monica?
How can we help you?
Yeah, how can we get you an appointment today? So when we use that statistic, 64% of the time the patient doesn't get asked. They don't get asked to make an appointment. There's conversation. We're answering questions about how much things cost. We're engaged. We're even building rapport. We're doing all the right things, and they probably really like us a lot. At the end of the phone call, there's this awkward silence. And we might even say, okay, well, if you want, let us know, that kind of thing. Or it's been really great talking to you today, but we don't get to that point where we say, you know what, Monica, would you like for me to get an appointment scheduled for you with the doctor? Or how about I go ahead and get you an appointment scheduled with the doctor? Does that sound all right with you? Sounds like you really want to get an appointment scheduled, Monica. Can I get that scheduled for you now?
I think if somebody calls there, they really do want to schedule an appointment.
A lot of times, exactly, and a lot of times the perception of the team member is they're shocked. How much is this? Do you take my insurance? These types of questions happen. So these barriers get formed by calluses from the dental team member. They're a service industry. They're there to serve the patient and answer the question. But if we don't ask for the appointment, the patient sometimes doesn't volunteer for it. Now, they may say no, and that's okay, as long as we get to a point where we ask. So what is the most important question we ask the new patient on the phone is, would you like to schedule that appointment? Now, there's a bridge between how long should a new patient phone call take and when do I ask for the appointment? That may be 2 minutes, that may be 20 minutes. You have to have the verbal skills to be able to be comfortable asking that question. So I think the next two slides are really great for doctors to take to their team members, just a real quick how-to on how to get the conversation flowing. And so I'm going to jump through this, and Monica, feel free to jump in, and you can be that patient, that feedback that we get on this. But a lot of times we say, thank you for calling Dr. Bell's office. This is Eric. How may I help you? That's a perfect introduction. Not good morning or good afternoon, not dental office. You have to have the greeting set up. That has to be done. That's number one. Patient will say something, Monica, they'll probably say, do you take my insurance? Or how much is a cleaning? How much is a crown in your office? Or Monica, what would you think a new patient would say when they call an office?
I'm looking for a new dentist, and I found you through the insurance company, so I'd like to make an appointment.
Okay, that's a lot of information, and that would be great if they said that. So that's perfect. And I would say, Monica, I'd be happy to help you out with that. Again, my name is Eric, and your name is.
Right.
And you'd say, Monica, and by doing so, I've taken control of the conversation because now I'm the one asking the questions. Okay? And you don't have to ask all these questions. Again, we got to be smart about the phone call. Do I have Donald Trump on the phone, or do I have Grandma on the phone? Which is it? And how are you going to manage that? And so, but I've listed out some questions that you can ask to make sure you have a good understanding where this person's coming from. It doesn't mean that you ignore the initial question. It means you get control of the conversation so that you have a good chance of answering that question. If they saw my name somewhere, I'm probably on a list. I'm going to be able to help them. If they didn't see my name, they say, I was looking, I didn't see your name, but I saw your website. I really like your website. I'm hoping I could schedule an appointment with you. I know I'm going to have a conversation with them. It's going to take a few minutes. So getting their name is an important part of this, okay? How long has it been since you've been to our practice? Now, that's a question I would not ask Monica in this question because she said I'd be a new patient. 8 times out of 10, that new patient does not state they're a new patient. They say, I'd like to schedule an appointment with your office, or I wondered how much X is, or I wondered, do you take Anthem Blue Cross Blue Shield? There's a question they ask because they didn't go to school to say, hey, when you call the dental office, make sure you say, I'd like to schedule a D0150 comprehensive examination, please. I'd be a new patient. That doesn't happen, right? And so when I talk to office like this, they just don't know what to say. Get control of the conversation. Be comfortable in your own skin and asking the questions that allows you to guide them through this process in a way that makes sense. The way they want to do it does not make sense. Do you take my insurance? No. Hang up, right? Yes or no questions are dead ends in conversations. You know what I mean by that? Somebody calls up and says, do you see kids? Yeah, we see kids. And they go, oh, I'm looking for a real quiet office. I'm actually leaving a practice where it seems like there's a kid screaming every time I call.
Yeah.
So the yes or no is a dead end to a conversation. You have to know how to engage in that. I'd be happy to help you out with that. Ask a question. Tell me about your family. Okay? So again, there's more training that can go on in this, and there's more to delve into, but this is what I typically see. The first few lines of that initial phone call can really get you in that control position, but yet still be helping the patient, okay? We say, how long has it been? Oh, I've never been there before. Great, new patient, wonderful. How did you hear about us? Who can we thank for referring to us? The assumption is people talk about us. Who can we thank? Okay? Now, why don't I just say, are you a new patient? If they haven't said so. Because if they're an existing patient who just spent $3,000 in our office last month, I'm going to offend them. And so, how long has it been since we've seen you in our office? It's a safe way to find out if they're a new patient or not. And if they're an existing patient, again, who comes every 2 years but they missed the last one, they'll go, oh, gosh, yeah, I think I was there about 2 years ago. Oh, great. And what's your name? First and last name, please. I'll look you up. Look them up. Oh, actually, it's been 4 years. It starts to educate them on their condition, which we'll talk about. So, continue on the phone call. There's some more important questions here. And I'm not getting into all of these, but at some point, you're going to get to the bottom where you say, why don't I look for an appointment for you to come in and meet the doctor? You're going to get to a point where you're asking that question. It may be earlier in these questions, but these are questions that you can have in your tool belt to go after that patient. Make sense?
It sounds like a great lunchtime
Yeah.
event with the staff to say, hey, let's go across some of these things that come up when they're calling for an appointment. Why don't you give us some examples that have been difficult? Yep. What if we changed the way we answer it to include some of these things? So it sounds like it's a great lunchtime training session.
I have the team, before they come to that meeting, prepared, writing down the number one question they hear on the phone, the number one question a potential new patient would ask.
Yeah.
Bring one or two questions, and let's talk about how we would engage that patient so they would want to schedule in our office. Almost every single one of these lines has a question mark after it. And there's a reason for that. There's a purpose behind that. So are you comfortable in your own skin? Are you able to do that? So the goal is to get that patient in, get to the point where you ask that question about scheduling them. Get them registered in your computer, find a time. Now, when? Have you heard any statistics, Monica, on how long motivation lasts?
No, haven't.
So about 7 days, psychologically, people are motivated. So January 1st comes along, we start setting a lot of goals. January 8th comes along, not so many of them are being done. Things fall off of our plate. We're on vacation when we set those goals. We've got a lot of time on our hands, right? Then we go back to work and life takes over. And so motivation tends to last about 7 days. Now, I would say a high fear patient, they're not going to go to bed 6, 7 nights, 8 nights worrying about that dental appointment. And so we've got to be prepared to see this patient within 7 days. We've got to have a system set up that allows us to do that. So diagnose your office. Look at how long does it take to get in. And again, we're all here, Jeff, Monica, we're all here to help you figure out a way. How can we make that possible? Okay.
Yeah, good information.
So once the patient's scheduled, we get them in. The goal is to build that trust and rapport, okay? So there's two principles to case acceptance. And again, I could spend a lot of time on these. We only have so much time today. But number one principle to case acceptance, to understand and have in the back of your mind all the time that this person that I'm talking to is going to buy for their reasons, not my reasons. My clinical expertise, my knowledge of what's going to happen to their TMJ is not motivating enough for them to move forward with this. So here's the question of the day. Do you know why they want their teeth healthy? They may say, yeah, I want them wider, brighter, and I want them to last a really long time. But if you don't know why they want that, then it's just your reasons, not their reasons. And in parenting, that's called because I said so. Mm-hmm. So we look in the patient's mouth, and we say, you need this. And in their mind, they're going, well, it doesn't hurt. And I'm pretty happy with my $1,000 in my pocket. I don't think I'm going to schedule that. And you wonder why your receptionist hears all the time at their courtesy calls, oh, I'm so glad you called. I was just getting ready to call you. Listen, that tooth the doctor was worried about, it's not even hurting me. I'm not even going to do that. It's not even hurting me yet. They don't have an understanding of what's going on, which brings us to principle to case acceptance number 2. People don't buy a solution to a problem they don't perceive to have. So in my mind, it's not hurting. I don't have a problem. So as a dentist, you've got to connect the dots for them. It'd be like a physician. And Monica, if I was a physician, you walked in, I took your blood pressure and said, well, Monica, we're going to have to do open heart surgery. But don't worry. We'll get you in about 7 days, and we've got care credit. It'll help you take care of it, okay? And
I stopped listening after you said open heart surgery.
Yeah, exactly, right? Or we're going to do bypass, or we're going to something major, right? So, and the whole time, the patient has no idea why. I'm not having a heart attack. I don't have any numbness. I don't have any you don't feel anything with high blood pressure. So if the doctor doesn't do a good enough job of explaining how the body works, you're not having pain here. But this is the condition. Intraoral cameras came in to save the day for us. Because as dentists and hygienists, we weren't able to express to the patient what we were seeing as a problem, which was going to lead to a bigger problem. So we would say things like, well, your old amalgam filling has a defective margin in it, and so you need a crown on that tooth. Still not enough. Looking in their mouth and saying you need a crown, need is a 4-letter word that must be avoided. If they don't have a good understanding of what the condition in their mouth is, they will not buy. People do not buy a solution, treatment, to a problem they don't perceive to have. And so if you're going to sell something in your practice, sell the problem. With my clients, I have a 95-5 rule. 95% of the time, they're allowed to talk about the condition. 5% of the time they're allowed to talk about treatment. And Monica, as somebody, again, as somebody who could be seen as a patient, right? You don't work in a dental office all the time. If I were to say, you need a crown to you, what's the initial thing you think about right away when I say you need a crown?
How much does it cost?
How much does it cost? And we wonder why we get so many money objections. Because we're going from A to Z, not A, B, C, D, E, F, G, down the line. And so there's some principles here that I want to quickly cover because I know we're on the clock here. So case acceptance is a huge part of overcoming these big operational issues when we say we don't have enough money left at the end of our month. Our patients are calling with emergencies with broken teeth all the time. People are walking out not scheduling, giving us financial objections because we didn't talk about this before we talked about the money. And we don't even realize we talked about the money because we just said the word crown. They instantaneously think about money right away, okay? So we're going to be having a conversation with this patient as if we were their mentor, their friend, somebody that's going to help them make a decision. Keeping in mind there's a huge asterisk to our profession because in dentistry, the same person who diagnoses the problem, in fact, Monica, you paid me money to come in for an exam. You paid me money for me to tell you the problems, and now you're also going to have to pay me, the one who found the problems, you have to pay me to fix those problems I found. There aren't a whole lot of professions where that happens. Our car starts to break down. We feel something different in our car. Something happens. We take it to the mechanic. How often do you go to the mechanic to get one thing done and they start talking about X, Y, and Z? In addition to that, you're going, no, I didn't have a problem with that. I know that's a lie, right? I don't trust this person. So in this presentation, we have to remember that we're about selling the condition. If they choose to buy the treatment, so be it. But we're going to sell the problem first, and not in intimidation, not in scare tactics, okay? We're going to do it in a relaxing fashion. So here's a quick checklist of what's going to be going on in this process. We're going to be focusing on conditions. We're going to tell the patient what it's going to lead to when it comes to consequences. Once we have this urgency, the testing, the buy-in, once we know they've bought in, then we can talk about treatment, the benefits of treatment, that sort of thing. Then we'll bring up the word crown, that 95% 5 rule. We're going to focus on that 95% first. And then you tell them what to expect afterwards, how long it's going to last, those types of things, okay? So here's the process. So, Monica, I'll have you be my patient for this, okay?
Well, I was going to say they have one thing in their favor is there's trust already built here. So
Yep.
I've been a patient for 5, 6, 10 years, and I trust my dentist. You know, if he
Yep.
says, hey, you know, we've been watching this, you know, we've been talking about it, but here's the time, and here's what's happened. So, okay, I'll be your patient.
And let's just piggyback that and say patients don't walk in and go, hey, I know you've been watching this, doctor. Isn't it time we do this? So the unscheduled treatment that's sitting in your charts, the patient is waiting for you to ask. Same statistics, 64% of the time, the doctor doesn't ask if the patient's ready to move forward. So they're waiting for you to say something. So in this scenario, you're a new patient. We met about an hour ago, okay? And we've built some rapport through the process, and we've talked about, hey, we're going to be looking at concerns, and if they're there, we'll talk about them. And one of the concerns, what do you think the biggest thing doctors diagnose? What do you think the number one thing doctors are diagnosing and treating?
Periodontal?
Yeah, gum disease, exactly. So we find gum disease. And in a stage 1 or 2 periodontal case, how much pain do you think is involved in gum disease?
A lot.
Actually, none.
Really?
There's no, and this is where all of our patients come into play. They think if there's no pain, there's no problem. People don't buy a solution to a problem they don't perceive to have. Problem equals pain. Okay, broken bone, it hurts. I need to go get a cast. I need to have it reset. Okay, I'm having a heart attack. I need to go to the doctor. Okay, so that's why we have to connect these consequences to the condition. So if you were my patient, I would say to you, I'd say, Monica, when we did the exam and you heard us evaluate the health of your gums, we used the ruler to measure. One of the things that was glaring at us was the amount of infection that was pulling up in the pockets around your teeth, eating away at the bone. The reason that's concerned, Monica, let me ask you a question. You ever see somebody who looks like really long teeth, they have those black spaces in between their teeth, and their gums look like they're too far away from their teeth. Have you ever seen that before?
Oh, yeah.
Okay. That's an advanced case of gum disease, okay? And that might be 2 steps, 3 steps away for you. But here's the kicker is how do you stop the snowball from rolling down the hill once it's already started? You can't do it on your own. So if you say to me, you know what, Dr. Vickery, I'm okay with that. I know I'm heading towards that. That's your decision. But I'm here as a professional to say you can still do something about that to stop that from happening. That is where the consequence of what's going to happen down the road if you don't do anything. Does that make sense?
Absolutely.
So now, even though there's no pain, they know what the consequence of that. And you could talk about mobile teeth. There's lots of things we could do, but we basically get to tooth loss and toothache. Those are the 2 consequences we focus in on. So if a patient's very aesthetic focused, we talk about how tooth loss doesn't look well, right? Or recession of the gums doesn't look well. If a patient's very much into avoiding pain, because they've had that before, we'll talk about how fractures in teeth allow decay to get to the nerve and cause a toothache. Those are the consequences we want to get the patient to understand. And basically, we're taking them to dental school. We're doing it in a way that they understand. And so that's this process. Now, once I do that, down at the bottom here, you see conditions plus consequences, right? That's the part I've done. And then I say to you, Monica, is preventing that from happening something that you're concerned about? That's something that you want to do. You want to prevent that.
I want to have my teeth as healthy as possible. I don't want to get into a pain.
Okay. Now I have permission to move outside of the 95% and into the 5%. And I say, well, mutual agreement here. I'd say, well, wouldn't it make sense then, Monica, for you and I to talk about the best plan of action to stop this infection from spreading?
I'm all for it. What do I need to do?
Great. Here we go. And then we move on. I'm going to leave this screen up for just a moment longer in case somebody's taking notes. But the point is this, is we get to a place where you say, yes, I want to fix it. Now I've earned the right to talk about treatment. I'm in my 5% realm for a moment, and then I get back out of it. When I walk back up to the front, I go up front and I see Jeff. I say, Jeff, Monica and I talked, and she wants to go ahead and stop this infection and come in and see our hygienist and get this taken care of. Right, Monica?
Absolutely.
Instead of walking up and going, okay, Jeff, we need to schedule 4 quadrants of scaling and root lining for 4 hours, Monica, and you hear the difference?
Yeah.
We go right back to that 95%.
Clinical. You're talking to the patient like they're a hygienist or a doctor, and they don't know what you're talking about.
And here's what you're saying, Monica, is it has no impact on the patient. It's cold. They don't get it. They don't do it. People would rather make no decision than risk making a stupid one, let alone a stupid one that's going to cost them $1,000. And so they have to have this understanding. And so hopefully when we look at operational issue of hey, we're not getting case acceptance, I don't have enough money at the end of my month, it's because this right here, boom, can make a huge difference in a practice, okay? So that patient goes up to the front, and we go over everything, we summarize. Please do not bore them with the mumbo-jumbo that you're so familiar with. You went to the dental school, you understand it. The patient does not need to be bogged down with that information. They have no idea what we're talking about, okay? Hemisections and TMJs and root canals. You'd be surprised what they don't understand. Talk to your friends who aren't paid, that don't work in the dental office, and ask if they understand some terms that you use. And you'll see them go, I don't know what you're talking about, okay? So keep it to a minimum, summarize it, get them on board wanting to fix it, and then get them out to your team member so that we can make sure we go over financial arrangements, okay? So we've got case acceptance. We move them out to the front, semi-private area, consult room, whichever it is, and now we're ready to present the financial part of it, okay? The number one barrier to poor finances in a dental office when it comes to this part of it is too much of it is done reactively. We're afraid. We're fearful to talk about money before. We're afraid if we talk about the money, they won't schedule. So we'd rather avoid that process, schedule them, have them cancel last minute or come in and do it, and then make payments or not pay at all, than have this conversation. So being confident in this conversation is really important. And so having the tools to sit down with the patient and say, now let's say I'm the administrator now, Monica, and I say, Monica, I'm glad you and the doctor came to an agreement on making sure your mouth is healthy. My job is to make sure that this is easy for you to do, that it's simple when it comes to handling your insurance process, and it's simple when it comes to handling the financial aspect of this. And so we've got quite a few different ways to make this comfortable for you. Would it be okay if I went over those with you?
I would really appreciate that.
And they say that every single time. They say, absolutely. Now, every now and then, I'm in a hurry. I got to go. Let me give you a piece of paper. I'm going to call you. We're going to do it by phone, or you can come back, which would work. They want to do it by phone. We'll do it by phone. That's fine, okay? Here's the deal. If you're going to handle your financial arrangements, it has to be done proactively, not reactively. As soon as you're in reactive mode, we're at a disadvantage. Do not schedule an appointment for a patient until clear financial arrangements have been set.
You would allow a patient to say, I have to go, and we can do this by phone later?
Well, like I said, that's an exception. If I know this patient, they're in a big hurry, what I don't want to do is schedule the appointment and have them leave and wing the financial arrangements. I still got to do things in the order of which they need to be done.
As I would say, if they left and you had talked about the finances, you're going to have a hard time getting that scheduled.
Exactly. As soon as they walk out the door, they're thinking about the rest of their life. Now, if the clinical team has done a great job at getting buy-in to a problem, that patient should walk out to me and say, I didn't realize it was so bad. I know I got to fix it. I know I want to do this. I'm in a huge hurry, okay? I've got to go, but I want to get this taken care of. That's the kind of thing that you should hear from your patients that walk out, not walking out going, well, how much is it going to cost? Can you send a pre-authorization in? I'm not really sure I want to do it this year. I might want to do it next year. That's a sign or a symptom that our clinical team is not engaging the patient in the buy-in of the problem. That patient does not believe they have a problem. Therefore, they're not too worried about spending $1,000, $500 on a solution. Does that make sense?
Yep, I agree.
Yeah, so we want them walking out in a different frame of mind. When they walk out to do financial arrangements, it makes sense. It all flows. So have some clear options that your team has agreed upon that you guys know will work. So the big three, 5% is paid by check in advance. Some offices let that slide, it's day of, but it just depends on the office and how that's set up. And so second option is, you know what, pay half today, whether it's copay or full, pay half of it today when you schedule, and the other half when you come in that day, and that way your balance is paid. That used to be half today, half when we deliver it, but now with same-day crowns, that's all changed. So if you're still sending to a lab, you might do half at prep, half at seat. The only challenge is, I would say this, is you have a greater chance of that patient showing up when half is paid today, okay? And the third one is some sort of third-party financing, whether it be care credit or some other, but you would say, we also have an option where you can make no interest payments over a 12-month span. Would that be something you're interested in? And you present all three of them, and you say, pick one. Give them a choice, not a chance. You don't say, well, how would you like to take care of your $500 balance? Well, I'll make $50 a month payments. Okay? We don't do that. We present three options. We either type it into our paperless system, or we have them sign something and we scan that in. The patient gets their copy of their treatment plan or their financial arrangements, and we scan a copy in, whichever it may be. Okay? Make sense?
Yep.
Okay, and here's some more notes on that. Make sure we're clearly presenting the fee. I would rather have our offices overestimate the patient portion than rather underestimate the portion.
Now, how will they know if they do need to get a pre-authorization so they know how much the patient portion is, if they're doing this right when it's being diagnosed? Exactly. So, again, experience trumps all. If you have a team that's very experienced with all the insurance groups and they handle those insurance claims they come in, they're going to know. Even my office I have that are fee-for-service, they still see some EOBs come back to them, and they start to keep a log, keep a library of what do certain groups pay, start to get a feel for that. There's ways to make sure the team is trained to know what's going on, where you're not calling for every single patient in the insurance company, wasting your time. You've got to have this down to a nuts and bolts system. Again, I'd rather overestimate 10% patient portion than underestimate. Patients are a lot happier when you're sending them money back than when you're sending them a bill. When you send them a bill, you are a liar, you are a cheater, you try to take advantage of them, you didn't tell them it was going to be this much. When you send them money back, you are the nicest guy in the world, right? Right. So continue to have that rapport. Let the patient know you're the one, your job is to make sure that the financial part of this is comfortable for them. That's your job, and you do it all day long, and you're always able to come up with a great solution for the patient, okay? Once arrangements are set, now we can get into ideal day scheduling. That's where we get into a process, and that's a whole other system that's really important. You can't just throw patients in. You've got to have it scheduled ideally. You've got to have it done right, and that's another topic for another day. So
Woo.
Wow.
I went a
you
minute
are
over.
on fire. You are on fire and covered so many great things, and some of them I hadn't heard of before. So it's great, like, the motivation, 7 days. You got to get them in before the 8th day. I think that's really important, is to get them, call them back if they didn't make a decision, follow up with them and get them in hopefully within a week's time or less than 2 weeks. That's really good.
Yeah, absolutely.
Well, Eric, it was great. Thank you so much for your expertise. I know whoever is online and listening is going to get a lot out of this. Hey, Jeff, do we have anyone that's got questions?
Let me check, and if you're listening on the phones, the lines are open, so just go ahead and speak up and ask Eric your question if you do have one. And let me check on our internet question. Eric, real quick while I'm checking, if somebody does have a question and they're listening on the replay later on, what's the best way if they want to get a hold of you from a phone call and an email standpoint to contact you?
Sure, and I'm happy to sit and talk with somebody. You set up a call with me, we'll talk and chat about things and how I can help and give you some advice. That's easy to do. My phone number is 530-356-4011. So it's area code 530-356-4011. That number is always in my possession. Eric is with a C, so it's my email address is Eric Your Coach, so ERIC Your Coach @charter.net, like you're chartering a plane. So Eric Your Coach @charter.net. You can email me questions. You can email if you want to set up a consultation, just to talk about issues in your practice. I'm happy to help. It's what I do. So
I can hear that
great.
passion.
Go ahead, Monica.
Yeah. I can hear that passion in Eric's voice, which is great. He's energized, and I know that anybody that calls, if they have any questions, you'll lead them that way, and hopefully if they need more than just a couple of questions, that you can help them out.
Oh, absolutely, yeah.
Well,
anybody
I don't see. Go ahead, Monica.
So you don't see anybody online?
No, the phone lines have been open. I'm not hearing any questions, and from the internet, we don't have any. So, Eric, you were very thorough, covered everything. Congratulations.
I'm sure, yes. Yeah, and I'm sure there's going to be more questions. You're welcome to email the questions, too. That's fine as well.
Super. Monica, anything else you want to add?
No, I thank you for your time, Eric and Jeff. Thank you both. We went a little bit over, but I know that they'll all appreciate it. And have a great evening.
Thank you guys so much.
Thanks, Eric. Thanks, Monica. And again, we want to thank everybody for being on the call, listening to the replay, too. The call today was titled Most Common Operational Issues Currently Encountered in Dental Practices, hosted by Monica Rebella CPA, President of Rebella Accountancy, with our presenter tonight, Eric Vickery of Vickery Coaching. Thanks again, everybody, and we hope to talk to you soon.
Good night.
Good night.